Good evening, everyone. I will be presenting on the spine metastasis and intervention radiologist perspective. So I would be describing about introduction, diagnostic, that is vertebral bone biopsy, therapeutic vertebral augmentation, vertebroplasty, kyphoplasty, coming on to management of spinal metastasis, that is NOMS, pain score, sin score, and review of literature. Coming on to the introduction, the spinal metastasis is most common site after lung and liver. The most common site of bone metastasis is a spine, which involves in 70% of the cases. The thoracic vertebra is the most common site, followed by lumbar and cervical. The most common cancer affected in women is a breast cancer, whereas in males is a prostate cancer, and the lung cancer is common in both. So as the surgical techniques have advanced, as chemo and radiation therapy have been advanced, and the survival of the patient with spinal metastasis has prolonged. So the bone metastasis survival patient has increased the lifespan. So what does bone metastasis cause? It causes weakening structural integrity via osteoblastic and osteoclastic activity, which causes collapse of vertebral body, vertebral compression fracture. Vertebral compression fracture occurs in 90% of the cases of multiple myeloma, whereas 30% of the cases of bone metastasis. So the goal of treatment and the goal of the treatment is a palliative, and it is multidisciplinary where all specialties play an important role. It helps in preservation, restoration of the neurological function, improved pain control, and improve the quality of life and maintain the spinal stability. So, a role of intervention radiologist in spine metastasis is a first in the diagnosis, that is histopathological histopathological diagnosis. It is CT guided or ultrasound guided percutaneous bone biopsy or aspiration, and another is a management of spinal metastasis for pain palliation and spinal stability, vertebroplasty and kyphoplasty, and along with that either ablation, which can be heat based, that is RFA, microwave, and the cold base like cryo energy needs to be delivered along with vertebroplasty. So coming on to the CT guided vertebral bone biopsy, it is safe, effective, accurate diagnostic tool as compared to open, and it is a daycare procedure and can be done on outpatient basis. So the common indication are for histological characterization of the focal vertebral lesions. It helps in the receptor studies, immunohistochemical analysis, and the vertebral fracture are difficult many times to differentiate between osteoporotic, metastatic, and inflammatory origin. Thus, a biopsy is indicated. So this was a case of solitary lesion in the C2 cervical spine, and you can see on post contrast there is significant soft tissue which is present, and transoral approach was performed as no other window is available. And whenever in lower cervical spine, when the body of the spine is involved, you need to hydrodissect between the vertebra and the thyroid. You can see here there's what it is closely linked, and there's hydrodissection which is performed, and you can also displace the vessels with the help of finger. And this is a case of nasopharyngeal carcinoma with bone with the PET avid activity in the cervical C5 vertebral body. So you can see here hydrodissection has been carried out, and the bone biopsy needle is entered into the cervical body, and the biopsy is taken, and it turned out to be inflammatory. So there are various approaches of the cervical bone biopsy, that is the anterolateral, as I shown, lateral approach, posterolateral, posterior approach. In thoracic, it's a paravertebral approach, costovertebral approach, parapedicular approach, and transforaminal approach. In a lumbar spine, it's a paravertebral approach, parapedicular approach, and so on and so forth. So this is the thoracic and vertebra which were involved with the metastasis, and transpedicular approach was performed in the thoracic and the lumbar vertebra. So and this was the transforaminal approach was taken in the PET avid activity of the dorsal vertebra. Coming on to the management of spinal metastasis, the treatment of spine is complex. It involves multidisciplinary tumor board meetings. Decision on making management of depends upon the four factors, that is NOMS. N stands for neurological assessment, O for oncological assessment, M for mechanical assessment, and S for systemic assessment. So neurological assessment can be done with the clinical and radiology. The clinical in as in presence of myelopathy or radiculopathy, is it present or absent, and on radiology whether anterior epidural compression is present or absent. So when the anterior epidural space is involved with the soft tissue, and if it is involved less than one third, then a vertebroplasty can be performed, and if it is more than two-thirds, then it is one of the contraindication of the vertebroplasty. And when whole of the vertebral canal is involved along with cord edema, then it is a contraindication of the procedure. You can see here there is significant cord compression in this, and this is another case where you can see one third of the bone is involved with the vertebra. So this is indication and becomes the indication of the procedure. So there are two types of pain which are generally involved, whether the pain is localized along with a radicular pain, or it's just a localized pain. The radicular pain is due to pressure symptoms of the tumor, and the management involves a complex complex, that is radiation therapy, chemotherapy, and steroids, and it takes longer time for pain relief, whereas the axial pain is due to compression fracture, spinal instability. Management is generally open or a percutaneous vertebral augmentation. Open is highly invasive and not suitable for this patient, and thus minimal invasive like percutaneous vertebral augmentation needs to be considered. The pain score, pain is a major complaint in the patient with metastasis. Pain evaluation is there's a fundamental requisite for the outcome of vertebroplasty. The pre-procedure score as well as a post-procedure vertebroplasty score is assessed always, and it's graded from 0 to 10, where 0 is being no pain and the 10 is excruciating pain. An oncological assessment needs to be considered, that is histology of tumor sensitivity to radiation, whether it is radiosensitive or radioresistant. There are various radiosensitive and radioresistant tumor. A mechanical assessment is predominantly for indication of intervention. When it is unstable or unstable, the spinal decompression needs to be done. Whenever there's cord edema, then spinal decompression needs to be done, and that becomes a contraindication for vertebroplasty. When the degree of spinal compression or radiosensitivity of the tumor as radiation therapy and systemic therapy do not restore mechanical stability of the spine, so either surgery or percutaneous intervention needs to be considered. And coming on to the SIN score is the most important feature for carrying out the stability or mechanical stability of the spine. So one needs to there are various parameters such as location of the location, location, the pain, the maximum pain, the bone lesion, that is lytic, sclerotic, or a mixed radiological spinal alignment, vertebral collapse, whether less than 50%, more than 50%, no collapse, posterolateral involvement of the spinal element, whether they are present unilateral, bilateral, and total scoring is graded from stable, indeterminate, and unstable. So when the score is less than 12, that becomes an indication for vertebroplasty. When it is more than 12, it becomes unstable and the surgery is indicated. The systemic therapy like comorbidities, overall disease burden needs to be considered. The treatment goal are focused on whether the patient is likely to recover from the indicated procedure, and systemic therapy can be given. So coming on to the indication of percutaneous augmentation. Percutaneous augmentation includes either the vertebroplasty or a kyphoplasty. The indication includes painful vertebra, either from multiple myeloma, lymphoma, or metastasis. This is due to extensive osteolysis due to malignant infiltration. Then is a stabilization of the vertebra in case of multiple myeloma and metastasis. Combination therapy, either you can combine ablation with vertebroplasty. Ablation can be heat based or cold based energy is given, or you can even combine angioembolization with ablation and vertebroplasty. The angioembolization is indicated in hypervascular metastasis, that is metastasis from thyroid and renal cell carcinoma. Coming on to the vertebral compression fracture is defined as reduction in individual vertebral body height by 20% or 4 millimeters. The aim of vertebroplasty is to consolidate the fracture, consolidate the fracture. Here you can see this is a case of multiple myeloma where on stir image you can see hyperintense signal. This is the patient where the patient had a D6 vertebral body collapse along with D8 vertebral body, and pain score is 8/10. So here the indication is for pain palliation. So it depends on the indication of the procedure, either consolidation or a consolidation or vertebral height restoration and pain relief. So the pain relief is due to following mechanism, that is stabilization of microfracture, chemotoxicity of liquid monomer, and exothermic reaction of the cement polymerization on the nerve endings. The patient selection depends upon refractory to medical therapy, doses of analgesia which are unacceptable, which have unacceptable side effects. When the pain relief is when radiation therapy can be given after vertebroplasty, one needs to rule out other pain, other causes of pain, that is disc herniation, which is most common, facial arthropathy, spinal canal stenosis, cauda equina syndrome. The treatment in case of acute compression can acute fracture can be given within the 4 months of the fracture. Correction deformity can be given. So contraindication of the procedure is bleeding disorder, uncorrectable coagulopathy, INR of more than 1.5 and platelet more than 50, less than 50%, unstable fracture, retropulsion of the fracture fragments, when there is arthropathy, facial arthropathy, vertebral canal stenosis, that become relative contraindication. When there is vertebra plana or vertebral compression fracture more than with height reduction of more than 70%, needle placement is difficult. Allergy to cement, tumor extension into the vertebral canal. So let's come on to the case discussion. This is a 61-year-old male with multiple myeloma. You can see here is a collapse of the L3 vertebra on a conventional radiograph, which is confirmed on MRI. On MRI, on the stir sequence, you can see hyperintense signal intensity at L3 lower body. Lower body, where the pain score is 4/10, sin score is 8/18. Here we are doing for spinal stabilization. Since there is collapse of the vertebra, it will further deteriorate, and there will be further worsening of the symptom. So what bipedicular vertebral needle was inserted, cement was injected. The cement is called polymethyl acrylate, that is PMMA, is injected, and this is post procedure conventional radiograph, which sees that a good deposition of the cement is seen, and this is a cross sectional imaging. So this is another case of carcinoma of prostate with vertebral mets. You can see here D6 and D8 vertebral body, there's collapse of the vertebra, and pain score is 7/10. Patient is on opioid analgesic, and patient has already received radiation therapy. You can see here these are predominantly dark on T2, which indicates that the radiation therapy is given to the patient. In view of this, needle placement was done at two levels, D6 and D8. Cement was injected, and you can see the post-procedure pain was reduced to 2/10. This is another case where, as I told you, hypervascular metastasis from RCC, angioembolization was done along with ablation and vertebroplasty, and you can see good deposition of the cement is seen. And post-procedure, pain score reduced from 8 to 0/10. This is a similar case from seminars where a patient is having multiple myeloma and there is collapse, compression, fracture on MRI as well as on CT scan. The kyphoplasty balloon was inserted and cement was injected for stabilization. And coming on to the response of percutaneous vertebroplasty, it's for pain relief in malignant fractures. It gives pain relief of 60 to 85%. 65 to 85% complication are the cement leakage in paravertebral venous plexuses, soft tissues, intervertebral discs. Rarely pulmonary cement embolism can occur. Leakage into epidural space, neural foramina, which cause radicular and paraplegia, infection, collapse of the adjacent vertebra, bleeding from the local side. So coming on to the literature review. This is a randomized control trial in Lancet Oncology. This is multicentric randomized control trial, which was evaluated for efficacy and safety of percutaneous augmentation compared to non-surgical treatment. When Ronaldo Morris Disability Questionnaire score was done at 1 month, which decreased significantly as opposed to the control. Though this was statistically significant, adverse effects were almost similar in both the arms, and thus in conclusion, kyphoplasty was effective and safe treatment. This was another systemic review of 111 reports in 4,235 patients from 2000 to 2014, where vertebroplasty and kyphoplasty was done for cancer-related vertebral compression fracture, and the pain score within 48 hours, which was more than 7 at the baseline, improved to less than 4. This was statistically significant, and also analgesia was reduced, that is the opioid. The complication rate were almost similar and leakage were almost similar, and no patient had a symptom. So when will you consider vertebroplasty versus kyphoplasty? Vertebroplasty is indicated in vertebral collapse when it is mild, or when it is mild, when the patient is having severe kyphotic deformity and there are multiple wedge fracture, kyphoplasty is the treatment of choice. So the difference between the vertebroplasty and kyphoplasty is not significant in terms of pain relief, vertebral height recovery, and post-operative complication. However, kyphoplasty is much more expensive as compared to vertebroplasty. And last review of literature, combination treatment with radiofrequency. Radiofrequency ablation destroyed the tumor lesion, or any ablative technique destroyed the tumor and thrombosed the paravertebral, intervertebral venous plexuses, which minimize the risk of cement leakage. After destroying the tumor cells, RFA makes the bone cement appropriately distributed. There is cavity formation, and the cement gets deposited into the cavity in an accurate way. The reduction of visual analog score from 8.6 to gets reduced to 2.6 in this study. The complication of epidural extravasation of epidural cement injection and intervertebral are there. However, they are not significant. Thus, image-guided radiofrequency ablation with vertebroplasty is safe and effective treatment. In conclusion, intervention radiologists play an important role in overall management of vertebral metastasis, right from diagnosis to management. NOMS assessment of vertebral metastasis management, pain reduction with vertebroplasty, sin score for vertebral stabilization, and thus percutaneous augmentation is safe, effective, minimal invasive treatment in reducing pain and improving the health related quality of life in patients with spine metastasis. Thank you.